Welcome to Care Transitions Today, Case Conversations, a podcast presented by the Association of Physician Leadership in Case Management and the American Case Management Association, where we dive deep into the world of healthcare case management and transitions of care. Today, we are joined by two physicians, Dr. Sweta Singh and Dr. Rebecca Sevier. Dr. Rebecca Sevier is a hospital medicine certified physician serving as Medical Director of Care Management for Advocate Aurora Health. With a focus on utilization review, quality management, and hospitalist program leadership, Dr. Sevier is passionate about evidence-based medicine and collaborative patient care. Her expertise and commitment make her a valuable asset to the medical community and a compelling voice in the podcast. Dr. Sweta Singh, Medical Director of Care Management at the University of Michigan Medical School, brings a wealth of experience in hospital medicine and a strong focus on quality improvement and patient safety. Her dedication to medical education and commitment to enhancing healthcare makes her insights invaluable to listeners eager to learn and grow in the medical field. In this series, we'll explore the challenges and triumphs of real-life case studies, providing valuable insights for healthcare professionals and anyone interested in the intricacies of patient care. Whether you're a seasoned physician advisor, a dedicated case manager, or simply someone passionate about improving healthcare outcomes, Case Conversations is your go-to resource for compelling stories and expert insights. This is Care Transitions Today, Case Conversations. Today, we have selected two intriguing cases to discuss. Dr. Rebecca Sevier will kick us off by introducing our first case.
And just to give a little context, we're reviewing this case on day 2 of admission. So this is a 36-year-old male with a history of spinal cord injury and now with bilateral above knee amputation, and has had some severe complications in the past. That he also has suprapubic catheters, spastic episodes requiring multiple medications to control that, and more recently a perineal wound that caused a spine infection, and now with the wound vac in place. The patient is on outpatient chronic antibiotics for this wound. Per the patient, he presented to the hospital because infectious disease doctor had that concern because of the high white blood cell count. And so they're worried about an infection and sent this patient to the hospital. In terms of symptoms, his only symptom is weakness and flank pains. In the ED, he was assessed and found they did the regular workup along with urine analysis, which was abnormal. Not surprising, he does have that suprapubic catheter, right? I was started on IV antibiotics and the infectious disease was consulted. And it has been now 2 days. Today is day 2 of the IV antibiotics. No signs of sepsis or any SIRS per se, so not febrile, not tachycardic. We are monitoring the wound vac, and given the whole concern and repeated infections, urology plans to change the SDC tube in 2 days. So they want to wait 2 days before they change. So here you are, this patient is on IV antibiotics. With white blood cell elevation was the reason for concern. What would you call this patient at this point?
Yeah, just a couple questions to clarify. So now the outpatient antibiotics, were those oral or were those IV?
Oral.
All oral, and we were doing IV coming into hospital. And objectively, the wound, we weren't sure if that was infected or not. They couldn't quite tell.
The wound, it has a wound vac. We are monitoring the output for sure. But It was not very much concerning objectively, like significant copious prolonged discharge to say, okay, definitely it's infected.
And which pair are we dealing with in
That's an
hospital?
excellent question, and that's where I was going to ask. So, say this is a two-way Medicare, how would you handle it? It's a traditional Medicare versus this is a private payer.
I mean, definitely if this were a Medicare patient and, given the spinal cord injury, it could be. I would definitely, it sounds like we have enough medical necessity for this patient to stay the second midnight. I don't feel like we have just social or non-medical reasons the patient's staying. It seems, very reasonable, level of care. Again, if you've got the high white cell count, unclear source of infection, you've escalated treatment, with IV antibiotics. And I think, anyone would be hard pressed to say, oh, we'll just give them outpatient IV antibiotics. You're not really sure what you're treating, and you really need to monitor closely for, the effectiveness or new signs or symptoms, especially in a spinal cord patient. They can hide infections, as very easily just because of, that loss of sensation. And it can take a little bit for them to declare themselves, so to speak. So I think I would vote for inpatient if we're dealing for sure with a Medicare payer or someone that follows the 2 midnight rule. Now, some other payers may, without a clear-cut infection, you might run into some issues. However, typically, I would still probably, if I talk to my physician and clarify, we're still looking at a few more days in the hospital with IV antibiotics and workup. I think with any payer, I would probably still try to go to inpatient, and I would, make sure my attending physician really puts in there what are they worried about, any, again, clarifying how the wound, maybe the wound bed, they took off the vac was concerning, more malodorous, or, any little details like that to just add credibility to the fact that we really do think there's a new infection going on. So was this your case? Did you recommend inpatient?
So this was actually one of our physician advisor's case that initially they called it observation and let's re-review, and then it came back next day. The patient is still on IV antibiotics, and we use this case as maybe especially for, like you mentioned, for traditional Medicare. When we know the plan is to keep the patient on IV antibiotics and there is continued medical need, and we have an explanation for the second midnight, they are appropriate to be switched to inpatient. So this was a traditional Medicare patient. But at the same time, made me start thinking, what if this was not? And this patient still needed to be in hospital, get the IV antibiotics, get the work going. And if the urology is concerned with everything, and because he has this small back and difficult patient that they didn't want to just replace the SBC supraclavic catheter in the ED, which is, let's be honest, if it's a 6 month, older than 6 month supraclavic catheter, it can be replaced pretty quickly. But they are concerned and they are ways to replace, so we know the trajectory of the patient. Then that's what I was thinking. Maybe if, like you said, and even if it's a private payer patient, commercial payer, documenting what we are most worried about. This is a high-risk patient. Spine infections are very difficult to manage, have high morbidity and mortality risk, and are appropriate to be closely monitored, worked up, and cannot be just left without proper treatment, right? We can just see if they actually start showing bad signs or symptoms. So I agree with you, and we did, like I said, called it inpatient. And these are definitely harder and great cases when it comes to more with the commercial payer.
Yeah. And I think the timing, I find especially for dealing with Medicare payers, that the timing of the order in relationship to when you actually discharge, the timing of the inpatient order in relationship to the discharge order is really important. Oftentimes it's much harder to get a patient approved as inpatient if you put the order in too close to the discharge. For example, maybe it's a 5-day stay, which you opt to upgrade in hospital day 4 when maybe that severity of illness is already starting to taper off. I find that I get more denials. Some payers will really look at what was going on when you put in the order, appropriately or inappropriately for the payment type that you get. For example, if you have a per diem, if you're paid on a per diem, meaning on a daily basis, every day they're going to approve inpatient or obs, and certainly those, it's even more important to make sure you get inpatient orders in place when that inpatient criteria are there. If it's a D or a G, really it should be, meaning we get paid one sum of money for the entire stay, no matter how many days the patient stays there. So for those patients, it shouldn't matter. But I do find that, again, the closer it is to the discharge order, it can just be a harder argument. So that's why I think for me that hospital day 2 is really that sweet spot. If you think they're going to be a couple more days, try to get them upgraded to inpatient. And I think I have less trouble with the denials than when I do that. So I don't know, what's your experience with that, Sweta?
It has been, you nailed it pretty well. Like that has been our experience too. So when we have these delay in conversion from observation to inpatient, some of the payers would actually just review the notes and things after they change to inpatient, even though we would sometimes argue like, hey, most of the majority of the things happened in the first couple days and they were really sick. And like you said, initially they are reviewing limited data and just making the determination by the time when they were in inpatient duration. I've had mixed experience though when it comes to peer-to-peer on those. I remember one time I was doing peer-to-peer with this care provider, and he was like, but when was the inpatient order placed? I said, well, the patient initially, isn't that what you guys like? Start as an observation. If they are appropriate or do not approve or we cannot discharge, then switch to inpatient. He's like, oh, absolutely. Observation period counts. So when was the obs order placed? And so this was also inpatient. He was so happy about that he agreed, and that yes, the day 3 patient is still, though not super sick, but not stabilized or not safe enough really for discharge, and is appropriate, even though it was down to 2 days of inpatient days after that, right? Overall hospitalization was 3-4 days. But on the other hand, some peers have really stepped, oh no, we got the request for inpatient days from date, which could be sometimes day 3, for example, and we're going to review only day 3 and day 4. And if day 4 was discharge date does not count, so we're not even gonna review that. And then we have to remind, okay, no, let's see. And I think just getting them to hear, sometimes it really depends on the peer, but sooner we make that call, the more that we are able to have that and the duration and the course to explain, it helps for sure. And for the peers are definitely harder when it comes to delivery, and they do go by when we switch them. We don't have that many party peers though, just very few portion.
Sure. Yeah, I guess I would say the same. We have few that are very, truly per diem pairs. So I think it's just helpful to know how your pairs behave around the timing of orders. And I agree, when I do peer-to-peers, I usually start off my peer-to-peer with patient was initially observation on this date, hospital day, 2 or 3, they were converted to inpatient and discharged on this day. So that they really have that whole picture of the length of stay. Because I think sometimes at least when I'm conducting a peer-to-peer and talking to the insurance physician, they don't always see all of that, the way that information is presented to them. They don't always get all of that information. And that oftentimes will make all the difference in how they view a case. So I think it's just helpful to, that's just my standard approach when I do.
That's good. I think I would try that next time for sure. Just give them, rather than waiting to hear what they need, struck a patient came into the ED. And no, we started doing, but then sometimes it would get too long for but I just stick to dates. But as a gold standard, that's always a good idea to start with. Patient came to ED on this day, was put on an observation on this date, converted to inpatient this date, and discharged on this date to get the whole picture of how long they've been getting in hospital care.
Yeah.
The Association of Physician Leadership in Care Management, or APPLCOM, was created to provide support and education for physicians in this field. APPLCOM is unique because of its connection to the American Case Management Association, focusing on the partnership and collaborative model of nurse case managers, social workers, and physicians in care management. ACMA has a rich 25-year history of supporting the case management field. AppleCom is inclusive of all practice settings. Membership in AppleCom also gives you access to all ACMA resources and benefits. Whether you're new to case management or have years of experience, AppleCom membership is valuable. Gain access to professional networking opportunities and resources. Visit www.applecom.org to learn more. Case managers, join thousands of your peers who have made the decision to further their connections, learning, and knowledge through ACMA membership. Access the Member Education Center with recorded webinars, CEs, and peer-reviewed articles 24/7. Visit www.acmaweb.org/membership to learn more. Let's continue with our second case.
We can transition. I've got one for you here. It's a kind of a short but sweet case here, if you will. So this is my case for today is also a traditional Medicare. It's an 82-year-old male who had, back in the 1990s, sometime had an abdominal or hernia repair done. It did involve mesh. And for the last couple of years, he's complained of some abdominal pain, mostly, kind of abdominal groin, maybe radiating to the flank, definitely precipitated by movement. And he talked to his PCP about that probably 6 months ago. He went and saw a surgeon. And at that point in time, they were just going to watch things. They thought maybe it's related to his hernia, but not really, or prior hernia in the mesh, but not really sure. But the surgeon at that point in time, didn't really want to go ahead with anything surgical, but really continuing to monitor. So this patient started to have an increase in that pain in the same location, but just more intense, had a little bit of nausea associated with it. There was some pain in the flank. He has a history of some kidney stones, but really felt like this didn't quite feel like a kidney stone pain to him. It was different. And occasionally had a little bit of dysuria, but again, not quite clear, that or similar to, prior times when he's had a urinary issue. So presented to the emergency room with these symptoms. They did their usual labs, nothing, white cell count, renal function was all baseline. They did check a urinalysis and just had a trace of protein. But they decided, it sounds, and he had some tenderness on exam, but it wasn't, no peritoneal signs. But they thought, because of the increase in symptoms, it's been long-standing, thinking that it was related to the hernia and possibly the mesh, and seeing if things had really progressed and maybe did need something more urgently done. They did opt to do a CT scan. So patient went for the CT scan, and that was a patient had come in the ED around noon, and at about 3:00 came back from the CT scan. And this is where it got a little bit interesting. So the nurse's notes indicate patient was very short of breath, very uncomfortable appearing. Heart rates had kicked up into the 130s. It was assigned as tachycardia. Respiratory rates were in the 30s. Blood pressure was like 200s over 100. And the patient was just really having a lot of difficulty. And so they did put the patient on oxygen, 2 liters. I didn't see any actual DSATs recorded, but I think because of the increased work of breathing, they did put this guy on oxygen. And they a little bit later, they did put him on BiPAP, and they were able to get the CT result back. The CT actually wasn't that exciting. It did show a small, inguinal hernia, some fat, containing some fat as well, but nothing, no bowel obstruction, no perforation, nothing really terribly interesting on the CT. But because there were new respiratory symptoms, the ED physician spoke to the critical care team to request for admission, just given the amount of distress. And they were thinking that this might be an allergic reaction, is what they were thinking, that this patient had a IV contrast reaction. And they gave the usual IV Pepsid, some Solu-Medrol, IV Benadryl, some Duonebs, and, continuing with the BiPAP. So what if you were the critical care physician or hospitalist that was being asked to admit this physician or patient? What would you, which status would you pick?
Yeah, no, that's a very interesting question and interesting case. I'll be honest. So by the time at first I was like, oh, did he have an allergic reaction to the contrast? And then I was like, he's hypertensive, not. And good. So I will get to hear what we were thinking and what the CT results were. And so at this point, now that I know the CT is pretty reassuring and that it is likely an allergic reaction with a good chance of it improving in 24 hours and things to settle down. None of these recover in less than 2 midnight. Although the challenging part is the intensity or the utilization of resources here. We are going to require every hour monitoring, right, for these, and especially in the ICU setting. I know, like, when you go by the Medicare 2 midnight exception rule, mechanical ventilation is part of one of the exceptions that we commonly discuss with patients if they require the intubation. But then this question was asked resulting that what about non-invasive, like does that count also as an exception? And if we go by closed monitoring on the DKA patients, they come in looking pretty sick, and they get hourly labs, etc. sometimes, and they recover. We know they will recover. So what do you do in similar cases? So at this point, because this patient, it's a little bit tricky situation. They may or may not improve, right? At the same time, even after giving the initial peptide sodium withdrawal, they're still tachycardic and hypertensive, requiring ICU monitoring. I would probably start as an inpatient for less utilization of resources that we have. And if they recover and are able to be discharged by next day, I would consider it more like an exception with a speedy recovery. Because again, once you do all this, the still patient came in with abdominal pain. Like, we haven't still completely treated that, or there is still possibility of continued kidneys beyond this midnight, is my initial thought. So what did you guys end up doing?
Well, this case actually came through to us as a short stay review to my physician advisor. So I definitely, if I had my clinical hat on and I was the admitting physician, I probably would have went the same way as you, thinking, the intensity of services, I don't know which way this guy's going to go. I'm going to make him inpatient. But our physician advisor, they had the opportunity to review this post-discharge, had the dilemma of, well, I know now this patient didn't even end up staying 24 hours. The patient looked much better the next day. So they had probably about 12 hours on BiPAP. And, respiratory status improved, remarkably. They got on some, blood pressure meds. They, patient didn't have any signs of, airway compromise, angioedema, those things. And even abdominal pain, apparently was not escalating into something more. So my physician advisor had all of that information laid out in front of him when he got the case, and had to decide, is it compliant for me to bill this out as inpatient, or should this be a self denial and, rebill for outpatient services? So, and I think you laid out a lot of the critical, medical decision-making pieces. I personally felt that, even if you argued against, like, there's allergic reaction, probably wouldn't need 2 midnights. I personally think if it's the case by case exception, that really it's one of those cases where you have a high severity of illness, risk of, something adverse happening to this patient, and the intensity of services is also high, that this would be very appropriate, even if you thought they would go home the next day, to bill it out as inpatient. Now, best case to help defend that is if the admitting physician documents that in the H&P and discharge summary, to really link it together and say this patient was appropriate for inpatient given the severity of illness and intensity of resources that we had to provide for this patient, and then link it back to what, maybe some specific examples of what that they were worried about for this particular patient. But we did opt to keep this inpatient, and I felt pretty good about this. Like if we had this audited, by the QIO, I think it would be one that would get approved, either just on their review, or if we had to have a discussion with them about the case, I think it's one that they would allow to go through as a one-night inpatient.
How do you handle your DKA along those lines?
I personally, if I'm dealing with a traditional Medicare, again, a lot of them I will consider for inpatient. As there's varying degrees of severity of DKA. Certainly if it's more mild, and some of these patients you can tell they'll probably only be on a drip for a few hours, and we'll probably get them on their long-acting insulin and be able to let them eat and start titrating their meal coverage and correction dose. I won't always go for those, but if it's really a sick DKA, the numbers, show significant acidosis, the patient's really symptomatic, maybe they've got, renal function is quite abnormal, I think those could be appropriate for inpatient as well. Again, I just like to see the physician that's doing the admission, connecting the dots. At least a sentence, tell me what makes this patient inpatient. So how about you? Is that in your practice as well?
So DKAs are always tricky and hard because, as you know, a lot of commercial cares are moving more and more toward admit them as an OBS, and if they continue to have care, and they'll convert them to inpatient, or their gap closed within the observation period. It's one of the things we often hear from during the peer-to-peer. So, with traditional Medicare, or if it's a 2-midnight pair, it's a more mental necessity based, their trajectory, and like you said, if they came in sick, there is a good chance they'll need time to stabilize and are appropriate for inpatient. But if they are those soft decay, they closes their gap pretty quickly, and we know we'll be able to, in ideal world, discharge pretty quickly. Those are appropriate to start as an observation. Definitely getting a good documentation to support that is essential, and something which comes with time and experience.
Yeah, no, agree. Definitely. Okay.
Thanks for discussing these interesting cases.
Yeah, no, this is great. I always learn something every time we talk, and appreciate getting your opinion on my cases too. So thank you.
Thank you.
Thank you to everyone for joining us for another episode of Case Conversations. We would also like to thank Dr. Savir and Dr. Singh for sharing their cases and insights in this episode. We would love to hear from the audience. Please join in on the conversation by visiting acmaweb.org/podcast, and don't forget to subscribe so you're notified when we upload new episodes.